We're starting this session with Professor DAMMAM.Horizons. He's already introduced twice in the previous session, so there's no need for further introduction.
No, go ahead.
Well,
I enjoyed it. Give me 15 minutes, just 15 minutes.
So, please have the mobiles on the silent, please, for things to go smoother without disturbance. Professor DAMMAM.Horizons, stage is for you.
Shukran. So I'm going to start this morning a little discussion with you really about the future of neurosurgery. We're going to take about 15 minutes before we talk about the anatomy stuff. But I think it's very important for us to engage, and I got permission from Dr. Maher because he's on the council, and I think the future is upon us, and I think it's important for us to make some big decisions. I'm going to start by asking this question, provocative question. Are more patients dying from meningiomas or from the surgery of meningiomas worldwide? Okay? It's a very deeply provocative question. And I think everybody in this room knows the answer, unfortunately. Okay? We actually looked at this data. We looked at it in a lot of deep, and unfortunately the data confirmed what we believe. What this question means is there's a major problem in the specialty of neurosurgery worldwide. Okay. The reason is this. Let's say some 35-year-old person has a petroclottal meningioma, they have very mild signs. Is that patient better off having surgery by someone who's not experienced in doing that, or better off not having any treatment? The answer is better off not having any treatment. Okay? We have to face this reality. There are patients all over the world being hurt. Okay? And we have gone too long without addressing this issue in our own home, in the home of neurosurgery. Okay? I cannot allow this to go on any further. I have taken one of the main reasons we created this day in society is ultimately look at the outcomes of patients. What do we need to do to improve outcomes? Meaning, all this stuff we're talking about, training, education, courses, curriculum, really is focused on one thing. I didn't say that up front, because if I mentioned that up front, a lot of people would be very excited. We said it's about education, about the young generation, it's about training, it's about education. All of that is oriented about the patient's outcome. So what I'm asking to do to reverse the thinking of training. Historically, we have trained in the Halstead method, meaning we put people through training and see what's best for them, and they graduate and they go practice. I'm asking to flip this over upside down. We say we have a patient here who has an aneurysm. We have a patient here who needs a DBS procedure. We have a patient here who needs a spinal fusion. How are we going to train the person to treat this patient in the best possible way? So reversing the whole thinking, how to achieve the best outcome. Okay? So this is obviously a lot of the old guard of neurosurgery are not very happy with this, but that is really not something that's going to stop us from doing what we need to do, which is the right thing. We cannot forget the reason we went to medicine and neurosurgery is to ultimately to help patients. It's not about us. In the field of neurosurgery for too long, with the ego in the field, has always been about the surgeon, not the patient. We have to change that. Okay. So I tell my fellows and residents, simple thing. Be an expert or don't be. Don't be a neurosurgeon. Neurosurgeon is not a field one can dabble in and just, do this and that and just get, a lot of people, get hurt as a result of that process. You may have seen some of my communications of the last few months about this issue. Essentially, the whole thing is based about improved patient outcomes. What is the number one thing we need that we have peer-reviewed data, published data and peer-reviewed literature, tons of papers. We have seen time after time the neurosurgeon who runs a subspecialty practice has better outcomes across the board in neurotrauma, in spine, in vascular, skull base, in functional. Every one large series we've looked at It's as simple as that. Okay? So that is what we need. What's the advantage of that besides this? Well, number one, that means every neurosurgeon is an expert and an educator. It's not those people who live in IV towers or professors in chairs of neurosurgery who are the experts, and everybody else is like just kind of listening to them. Every person should be an expert and educator. That leads to better development of research in all institutions, academic and private. That leads to better patients' outcomes. Okay? Now, we are moving towards a board type of patient management style at major institutions. Meaning, if you are a vascular expert, you run a board with neurologists, with interventional neuroradiologists, with the other disciplines, and you then review the complex cases, and you make a decision together. AVM, aneurysm, stroke, whatever. You cannot do that if you're doing 1,500 other things. You only can do it if you focus yourself towards the kind of practice you want to run. You know, so, and that's true for spine. You want the orthopedic spine guys, you have the neurosurgery spine, you have everybody in one room making a decision about somebody who has a spinal tumor. Okay? So board kind of multidisciplinary decision making is best for the patient. Okay? It is the best way to manage patients, especially brain tumors, for example. You've got to have brain tumor boards if you are operating on brain tumors. For gliomas, you've got to have the radiation doctors, you have to have chemotherapy doctors, you have to have all the teams in the room to make the decision for the patient. You can't anymore just be the one person, okay, this is what we're going to do. We want to have multiple opinions to have the best. The only way you could do that if you run this kind of practice. Neurosurgery is a very young field. We need a lot of clinical trials. The only way we can enroll patients in clinical trials is by you having this kind of practice. Because through these multidisciplinary boards, we enroll patients into trials. Okay? What's happening in the future? In the United States, as part of the Obama healthcare, reimbursement is going to be linked to outcome. And believe me, the world is getting very small. Don't think this is not going to come here or elsewhere. So based on the patient's outcome is what the reimbursement of the surgeon is going to be. All right? So those people who, so this is not just best patient outcome, it's ultimately going to affect the financial reimbursement of the doctors as well. Okay? So this is a model that I have put together that we would like to see discussed in the larger arena of neurosurgery and to see how to do that. What this means, it changes the paradigm of neurosurgery in a big way. Indirectly, what I have said now, that neurosurgery can no longer be practiced by one person group, by one private guy working by himself. Neurosurgery is not a kind of specialty to do that. Okay, you just cannot do that anymore. Okay, so neurosurgery has to be practiced in 7 or 8 person groups, where each person does something else, and they refer patients to each other. They're no longer competing because they're all doing something different. And among themselves, they send the patient to the right person. What that means, regionalization of care. Meaning, there are no two, most of people misunderstand neurosurgery. There are two parts of neurosurgery. There's acute emergency neurosurgery, something coming with epidural. But most of neurosurgery is really elective practice. Meaning, if you ruptured aneurysm, it's not an emergency to be done at that hospital the patient arrives. Within 24 hours, the patient could be somewhere else, or could be coiled or operated on. So this idea has to be, so neurosurgery has two worlds. It has acute neurosurgery, which is an acute emergency. Patient needs to be done right away. And then you have the world of elective neurosurgery, where you schedule the patient the next day or 3 weeks from now. Neurosurgery currently is mixed. These two spheres are mixed together. And I am arguing these are two different spheres for the patient's outcome, and we have to look at it that way. So the question then was raised to me by a number of boards around the world. How do you envision training somebody who is now an expert in one area, yet is an expert in dealing with tell us how you're going to do that. So this is what I have proposed as a model. Okay. I believe neurosurgery should be 7 years of training. That's the ideal amount of time to train a neurosurgeon. The first 4 years is what we're calling acute neurosurgery training. These are, every neurosurgeon has to know the acute emergencies of every part of neurosurgery. Okay? And I'll explain that further. So everybody has to know how to deal with cranial trauma, spinal trauma, with an MCA aneurysm that comes with a temporal lobe hematoma. Acute emergencies where a patient is dying, every neurosurgeon, because you take call, you have to take care of it, okay? After this, we have an exam, make sure they have met all the paradigms for acute neurosurgery, meaning they understand acute neurosurgery very well. They can handle any patient coming to them with acute emergency. Then I want people to spend a 1 year of research in the area of their interest. Right now in the United States, we have a research here. And the guy will do research, whatever, and brain tumor. And then he goes into practice, and let's say he does only spine. So he wasted a year of research, a year of his life during residency for nothing. So we are linking the research to the area of interest, meaning you invest a year learning and researching in the area that you're interested in. Then you go into a subspecialty last 2 years of training in a high volume center. What I said in my last slide is that the outcome is related to the high volume of the neurosurgery, meaning the more cases you do, the better outcomes. So to do the subspecialty year, not every program in the United States or elsewhere can train everybody in everything. In my program, for example, I can train people in vascular and skull base, but somebody want to become a complex spine surgeon, I prefer if they were in a program that did a lot more spine surgery than we did. So in big countries like the US, we want to create a network of exchange, meaning we exchange a final 2 year resident based in the best centers that can train that person. Now, how about other countries where you cannot have those kind of programs? Like if you go to Romania and you want to train somebody in functional, where there's no one in Romania who can train your resident in functional neurosurgery. So we're creating a network of countries that will then exchange the last 2 year person. And this is why this is an important conversation here. So if you have your last 2 year person and they need to do functional neurosurgery, or which you have very good programs here in Riyadh, but let's say you want to train them in something you don't have a big volume center for, okay? You can send them to a country, let's say France or Germany or the US, and those countries also can exchange with other countries. It creates a fraternity of programs under our umbrella that will then train those people at the highest level to go back. They only graduate from this program, so you're not losing your resident. They graduate from your program, they're your resident. They just go do those 2 years and come back to graduate, okay? So nobody loses anyone, okay? At the end, and for the first time in the history of neurosurgery, we are putting together boards, subspecialty board examination in neurosurgery. We want to make sure these people have met the standards, the highest level of standard of that subspecialty. Now, just to be politically correct, people who are currently in practice and have subspecialty practice are going to be allowed to transform the system to sit through this exam. So that means this generation that's before us, that's already doing their practice, they can take this exam. It'll be in the US, it'll be certified by us. And then they can be the first generation doing this until these people come and meet them in their programs and become part of their program. So that will be the final certification. I hope that the leadership in the kingdom in neurosurgery will seriously consider this. I believe this is the future of neurosurgery, okay? People say you cannot change the past, I say you cannot change the future. Patients all over the world on the internet are learning everything. This is not like the old days where the patient just willy-nilly is going to believe everybody's going to tell them. I'll tell you why I thought about this whole issue. A few years ago, about 7 years ago, in the state of New York in the United States, the health officer of the state of New York was looking at all the data of the different hospitals. He noticed something very peculiar. He said in certain hospitals, certain places, people undergoing coronary artery bypass surgery, CABG, were having very high mortality. In other places, they were having very low mortality. He kind of noticed this among a lot of numbers that were coming across him. He said, this is something really funny about this. Why? For adjusted for risk now. This is data adjusted for risk, for age and comorbidities and everything. So they started looking the whole state of New York and every hospital to figure out what it is. They found out something very simple. Surgeons who were doing more CABGs had better outcomes versus surgeons who were doing a lot less. So they said, okay, the medical field apparently, the cardiothoracic surgeons are not going to police themselves. So we're going to do it. We're going to do something very simple. We're going to put on the internet in the state of New York the outcome of every heart surgery, what their mortality rate is. And they're the government of the state of New York, they put it on the internet. So this is the mortality of Dr. S, Dr. X, Dr. Y, this is his mortality. You know what happened? Within 6 months, 20 heart surgeons in the state of New York essentially had to stop practicing. Nobody went to them anymore. They started to quit cardiothoracic surgery. Okay? So if the field doesn't police itself, in the future, administrators and governments are going to do it. Now, isn't it smart for the field to take the lead and have somebody else come? Could you imagine 5 years from now that your outcome of aneurysms, AVMs, tumors, functional, spine is on the internet and patients are looking this up before they come and see you? Okay? That's going to create a big problem, all right? Because now you are in a difficult situation to explain those outcomes because you're doing so many different things. So if we get ahead of the game as a field of neurosurgery, we can change this thing. Secondly, the biggest fight I'm having with a lot of boards is this issue of subspecialty practice. A lot of the old guard think that there are people in our field who feel that they're experts in everything. Okay, I have been trained by some of the best neurosurgeons in the world. I have never met a neurosurgeon in my life who is an expert in every aspect of neurosurgery. There are a lot of people who believe this, but reality and perception is very different. No such person exists, actually. Because in the 1960s, there were only few procedures and few things you needed to know. So the board examining those procedures, that's fine, you are an expert in all those things. Today, just the literature, this means when you live this life, you know the whole literature about your specialty. Every year, in aneurysms, there are about good 100 papers that everybody who does aneurysms needs to know. Same thing for spine, same thing for functional, same thing for pediatric. How can a neurosurgeon know the whole literature of neurosurgery and be up to date about what's going on in every field? Forget the technique, forget everything else. Just think about what we expect them to know about what's going on in neurosurgery in their area. Impossible, okay? So this is what the issue is. 100 years ago, Harvey Cushing walked in the operating rooms at the Hopkins Hospital. He was a surgeon. There were no specialty for neurosurgery. And that day on the board, he saw there's an abdominal operation, there's a thoracic operation, there is a thyroid operation, and there is a brain tumor operation. And they were going to divide among themselves as to who's going to do what. There's no neurosurgery. I mean, everybody does everything. He said to himself, you know what? For neurosurgery, this is not going to work. I mean, how can I one day be doing abdominal operation, thoracic operation? So he, the first time, split neurosurgery from surgery as a separate specialty for a very valid reason. It's based on outcomes and the evolution of the field. A few weeks ago, I walked in the operating room of my group. One of my guys was doing a DBS procedure. One was doing a third ventricular tumor. I was doing a bypass for a giant aneurysm. One of our guys was a minimally invasive spine procedure, and one was downstairs calling an aneurysm. I will argue the differences I saw that day are bigger than the differences that Harvey Cushing saw 100 years ago. Okay? So it is high time for us to take a major lead in making a change in this area. Luckily, a few countries globally have already accepted this model. And as early as July 2014, الدفعة الأولى, the first group of people to enter this program will occur this year in 2014. Okay? We are going to follow them very closely through our World Headquarters office. We want to really make sure that this generation, this new group, batch, gets into the system. And we want you, those of you already in practice, is to really, within the next 2 years, the board examination will be available. For you to, it requires 2 years of submission of outcomes, of submission of all your cases, and you have to meet that to sit through the exam, and you can sit through the exam to get the certification for it. And those of you who are residents currently, it is possible if you have already 6-7 year program, that your program director allows you to finish your acute training so you can spend the last 2 year training in a specialized area that we can help you with. But I don't want to put any words in the mouth of any program director over here. It is their discretion and their decision. And Those of you who are at the end of your training, I would highly suggest that you enter some kind of a subspecialty program and be in communication with us so you can sit through that exam. The main issue here is there's a gray area that for a while we're going to allow it for probably 4 or 5 years, we're going to stop. These centers have to be certified by us. We have to make sure that they have the numbers and the quality that meets the standard for ultimate certification. For a few years we're going to allow this, but there is going to be a mark after which it's only going to be for people who've gone through the system in centers that have been certified globally. What this will allow, that globally you have colleagues who have the same certification as you, and you could be in exchange with them, you have your meetings, you're all at that level. So you can all be entering patients in research projects and evolving neurosurgery. The evolution of neurosurgery in the future is not going to be general neurosurgery. It's going to be each one of these areas that you're going to be part of, any one of them. And those are the people that evolve neurosurgery in the future. It cannot be evolved the way it is today. It's just too confusing. So I think, I'd like Maher and his colleagues to really seriously look at this. In some countries what has happened, obviously changing things at the government level with all the red tape and bureaucracy is not easy. And it's not easy in this part of the world as far as I know. So what people have done is that individual programs said, okay, we want to be part of the system. Because they already are fulfilling all the criteria that their current residency requires. Because in 7 years, you're going to fulfill all the criteria that currently you have. There's no way that in these 4 years, they're going to fulfill the criteria that they're currently required. That program, the chairman and the program director said, okay, I'm going to make my residents fulfill everything I need from them from general here, then I want to put them through this program. And I will highly recommend program directors in this country seriously consider this. And I look forward to hearing from some of those program directors and say, listen, we really seriously want to be part of this, and we want to enter our residents into this program. It is ultimately you, the next generation, who's going to really need to make this difference and this change. And we sent a questionnaire to all U.S. neurosurgery residents. We have close to about 1,100 residents in the United States today. 95% strongly are supporting this model, meaning the next generation is supporting it. There's nothing in the world that can be done to change that. The only thing is, people can make it painful for us and delay it by 2 or 3 or 4 years, and they can, believe me, they're capable of doing that, and I won't doubt it. But it is what it is what the next generation wants. More importantly, it is the right thing for the patients, for the future patient. Patients like my sister, my mother, your brother, your sister, those are our people, and they need to get the best care. And that's what's better for them, okay? Let's leave all the politics, all the egos aside, and let's do the right thing. So, how do we do this first 4 years? Well, we are creating a curriculum that defines what people need to know. And this is just a fluid situation. But for trauma, all trauma. For vascular, somebody comes in with a temporal lobe clot, that patient is hard to transfer somewhere else. How can a person handle that? Pediatric. Any child with an epidural hematoma. Currently, pediatric, as you know, is already split off from neurosurgery a long time ago. But the problem is, in the US, for example, an adult neurosurgeon will not touch a pediatric patient. Well, how about a patient with an epidural hematoma? It's going to take you 2 hours to transfer that patient. It's not right, okay? So I want to bring back pediatric neurosurgery under the umbrella of neurosurgery, saying if you have a child who has epidural hematoma, you are trained and you are certified by us to take care of this child, okay? And the peripheral nerve, sharp injuries of the nerves obviously have to be dealt acutely during trauma cases. Mass effect from a tumor. If you're not a tumor surgeon, when somebody comes in with a mass effect from a tumor that needs debulking, I think every surgeon needs to know that. Skull base, those who are epilepsy, somebody who's losing vision acutely. Everybody has to need to know how to take care of that. So on and so forth, okay? So how do we do this subspecialty? Clearly, it cannot be exactly just a subspecialty. It has to be a practice model. So we have created a number of models. This is based on a questionnaire we sent to 360 neurosurgeons who practice subspecialty practice. So the first category among 12 is cerebrovascular and endovascular. We have the evolution of what's called a hybrid neurosurgeon in vascular. They do both microsurgery and endovascular. And that is a great category for them. Then you have cerebrovascular or skull base for those people who like to be in the operating room and do microsurgery and want to do both vascular and skull base tumors. And that's that category for them. Then you have functional pain, you have neurotrauma and critical care, you have pediatric neurosurgery, you have peripheral nerve surgery, you have tumor surgery and neuro-oncology for people who are very interested in research and doing tumor surgery. You have people who want to do tumors, both intraaxial and extraaxial. And then tumor and functional is another category for people who mostly work with the brain tissue itself. Then you have spine surgery, you have spine and pain, you have spine and peripheral nerve. And the caveat being that the person does 80% of their practice in the category they pick. So it still allows 20% of other things that they have to do. So that is the model that we have proposed. And, and I think it is a concept that we really are promoting and discussing with leadership globally. We feel neurosurgery is becoming a very small specialty. By potentially this certification, there may be avenues for people to practice their specialty in other countries because they all have met the same standard, but that's a different issue that involves a lot of ministries of health and so forth, but that is a separate issue, but that is a potential possibility. So Maher, I think, do we want to take questions on this or should we move on? What do you want to do?
Thank you, bro. I think this is what all the specialties is going to be someday. The trend now is just every specialty will be split from the mother specialty, like we're all medicine. There is no medicine or surgery, so the surgery is split from medicine. And then from surgery, there's a lot of other specialties split. And then I think there will be, with lots of knowledge and lots of subspecialties, there will be splitting of these subspecialties from the mother specialty. So for we go ahead with the thing. Just I have one thing to say. For the United States, how this was conceived. You said there is lots of you sent a questionnaire and it's going to be like this.
Yeah. Well, we sent the questionnaire to the U.S.
Something.
95% of the residents.
Yeah. They accepted this model.
Yes. The problem, and I'm going to be very frank here, it is what I call the old guard of neurosurgery. There are people, I'll tell you what the problem is, I'll be very open with you. The biggest problem we're facing is in Europe. And you wonder why Europe is the biggest opposition to this problem. Look at Italy, for example. In Rome, so they have few professors in the country who are the program professors. Everybody has to work for the government in the morning, and in the evening they have their private practice. Only the professors have the high-end private practices. So every patient, if you have a third ventricular tumor, you have an aneurysm, you have a disc, you go to the professor, and he's the one who makes the money in doing these kind of cases. So these guys do not like this, because what it means is that once this model is established, there'll be people who are experts in the spine doing this, there'll be people doing tumors, there'll be people doing peripheral nerve. So financially, they find this a model that is not good for them. The problem with this generation, for long they have only cared about themselves, and still today they only care about themselves. See, the guy is not worried about the patient or their outcome. He's worried about himself, okay? And that really is the biggest single problem with this issue right now, is those guys who are entrenched in very powerful positions who are saying, no way that we want this kind of thing, okay? The point Maher made is very important. It's a splitting off of specialties, and it's happening in every field, obviously. What this allows is to protect neurosurgery under one bigger umbrella before splitting off occurs. See, if splitting off occurs like it occurs in our specialty, there will be no control from the bigger field of neurosurgery. This model allows neurosurgery to stay under one umbrella. I want all those 6-7 people practice in one practice together. So you see, it is envisioned to protect a specialty, versus there is movement in the United States by some group of spine neurosurgeons who want to separate spine from neurosurgery completely. See, that's a dangerous model because that completely separates it. So this model allows it. The idea of subspecialty certification is not new in other specialties. Imagine, neurosurgery is the most highest risk specialty for the patient, from mortality, morbidity standpoint. Other specialties much less riskier than us. In 1978, OBGYN split off into multiple subspecialty boards for GYN, for OB, and everything. Radiology, which is really, I don't know what the risk is in radiology, already 5 years ago in the United States created multiple subspecialty boards. So the neuroradiologist has a separate board from the body. And so you're telling me we are the highest risk specialty. We have the highest risk to patients. We're going to be the last specialty to have subspecialty examination. That tells you the mentality, really, this very backward mentality that exists. Okay, and the reasons for it many. One of them is financial. The second is political. A lot of the old boys think they're going to lose political power. See, guys in these old guys in the departments, when the case is presented, so he's got this young spine person, the vascular skull base, but he ultimately is going to say the final word because he's an expert in everything. So he's going to tell you what to do with that patient, not the guy who's... So the minute you do something like this, that chairman feels like they're losing power in being the big guy, the guy who makes the final call about everything. I think until this generation, I think it's going to be a problem until we go through this big ego trip of neurosurgery that exists. And, so clearly there is opposition. I'm not standing here saying... The reality is, I believe, based on the response I've gotten in the United States and worldwide, it's just going to happen. Okay? This is going to happen with or without people who are opposing it. And the only thing is, it's the timing of it, really. That's the bottom line. It's the timing is the issue. And I think the easy way that's been for many countries, even in those countries where there's some opposition, that singular program said, we want to enter our professionals into this program. We will still meet our qualifications. So we're not going to in any way divert from what we require, but we still want to have this, because I want the functional person, I want the spine person, finish this program, and come back to practice with me. So it's possible to enter this without having some grandiose, large agreement at the country level. I think those are going to be more difficult to achieve, because you will always have people who will oppose just to oppose. And so I think the idea is, I just want to make sure the young generation is aware, and the progressive program directors and chairs to really think about this so that we can move forward for what's right for the field. Yes, Dr. Amr.
I think it's a great model. I've always been a great believer in the subspecialty training and or subspecialty model of training. And I could see during my residency, the guys who were interested in spine, they always preferred to go to the spine and avoid the aneurysms. So by themselves, they were some way or another doing it. And now in practice, take two neurosurgeons in the city of Riyadh, take for example Faisal and myself, we do completely different things. So this is I think it's a great evolution, and I hope we can adopt it. I'm just thinking about the challenges that we have here. There are surgeons, a lot of them, they are still practicing the general neurosurgery. Maybe I see many of them, they are kind of going into preference, so they prefer to do tumors or aneurysms, and that can be considered. So that leads to the second question. Do you have a set of criteria? I'm sure you have. How do you accredit a center, for example, for spine training for the last 2 years, or cerebrovascular? At least if you give us these things, we can actually develop into more deep thinking about this.
Yeah, well, thank you, Amrullah. Those are very good questions. Yes, we have a whole committee that is right now going through the criteria that is going to ultimately accredit the center. The criteria, as you can imagine, is it looks at the number of cases one resident will be exposed to, the final 2-year resident. So if a center does X number of cases, they may be able to only take 1 resident. But they have a huge number of cases, they may not be able to take more than 1. So we're going to define the criteria per person, how many people that person. So that's one aspect of it. The second is obviously, so that involves the number of cases that are being done. And second is the quality, obviously, so the outcome data. So that has so many different things to it. And we'll look at the outcome, make sure it meets the standard acceptable outcome for different types of diagnoses that we're going to define for that. And obviously, the third arm of this, which has to do with technology and research, meaning, does the center have, image guidance? Does it have, these kind of, that is required for that. So if you're doing brain tumors, you really want to make sure that they have all the basic technology. It's not like we're going to say every center has to have intraoperative MRI, but image guidance. Do they have a research arm? Can somebody be exposed to research? So those are the kind of general things we're looking at for centers, for various things. If they meet that, then they become a center that meets the requirement to train residents in that area.
That's, I can see the numbers, it's easy to calculate. The image guidance and the facility, the challenge here comes with the outcome.
Yeah.
The specially standardized outcome on our part is a little bit more deficient. So
yeah, that's the biggest challenge in everything we face. The reality is so much of the DAMMD accreditation for individuals or centers is based on prospective collection of data. We are creating a computer-based system at the world headquarters in St. Louis. Very simple system by which people enter the cases prospectively. Just the basic information, then follow-up data, okay? So that way, and this is all blinded, so nobody ever else shares that information. This is all completely blinded, but that allows us to see the surgeon and the center, how they're performing in general, okay? And it also adjusts for risk. So patients who are very sick, for example, we have all the things that look at their risk prior to surgery, because academic centers always are at the receiving end of this, because you get really sick patients. So if the patient is very sick to start with, we have to adjust for that for every procedure, But for that procedure, for an aneurysm, adjustment is the size of the aneurysm and location. Currently in the United States, when they adjust risk for neurosurgery, they look at general surgery. They say, does he have cardiac disc? Does he have a thoracic? They don't even look at the aneurysm, where it is and what size it is. So suddenly you're losing out adjustment. So we're creating a very specific system that looks for neurosurgery itself. For spine, it would be, the levels and so forth, and the curvature. There's so many things that you look at. So even if you're doing a simple procedure, those basic data could be added.
Yeah, wonderful. Thanks for sharing, please. Pass it over.
Thank you, Dr.
To make it short, because
this
program.
Yes, it's not
Okay.
Thank you very much, and it's a phenomenal way to look at things and to improve our training. I'm a recent graduate of training, and I believe in this model. But one of the things that we will face in our country is the intersectional problems. So this outcome is for group practice. Here we cannot have group practice because a patient who belongs to the university will be in the university domain, and the one in the Ministry of Defense will be there, and so on. So we have to, for us to start changing our minds to cross the section barrier, and patients could develop, or we can develop a center of excellence in certain fields, regardless of the base of where the patient comes from. Because that is a big hindrance to creating a specialized
The model
practice.
is already present. In Canada or United States, they have embedded subspecialty.
Yes.
So they have 6 years of training and they have 1 or 2 years of
Yes.
subspecialty, but they don't have the certification
Yes.
for the first.
Yeah.
So it is kind of certification which is for the initial one. The acute general surgery, I think this is a general neurosurgery rather than acute.
Yeah, it's general, but I'll tell you what the difference is. For example, when I was a resident, I sat through hours of procedures that I knew I would never do. Today in the United States, we require people to do X number of DBS cases, okay? And we require people to do endovascular as part of the training in neurosurgery. Majority of these people will never do neither one of those procedures. So that time wasted in those residents to do things, so it's becoming like a high school, like, you get a feel of this, feel of this, we're diluting the whole training. So acute is different from general, that is directed at things you have to know because you may have to do it, versus you have to know everything about neurosurgery. So it's not a yeoman's book kind of thing, everything. So that's the difference. I think it's a fine difference, but I feel it's a very important difference. We're not going to teach them elective procedures during the 4 years, like how to do a DBS procedure, because there's no emergency DBS procedure. So that's why I think it's a little different from that model.
Okay, so this model, I think it contains both the time-based program and also the competency-based program.
Right.
Because the resident has to be competent, a general neurosurgeon, in the first 4 years.
Right.
And this is 4 years, which is time frame.
Right.
4 years for the whole thing. So they have to be competent within this
That is
4
correct.
years.
That is correct. That is good. It's very tough, but 4 years, it's a long time. I mean, 4 years, if you do it right and you do have the right programs, that we're going to provide a whole set of curriculum for the 4 years as to what has to be achieved and numbers in each area.
So it has to be condensed in a way.
Yes, it has to be condensed.
Yeah. Because all the programs are 5 years, 6 years.
Right. Yeah, but 5, 6 years include a lot of elective procedures of everything.
Yeah.
And we're taking that out of the 4 years.
So it's 5. The traditional thing is 5 years.
Yeah.
And they have to be competent by that. So we have to shorten or
Yeah.
shrink it to 4 years for this competency thing.
That is correct.
Okay.
Okay, I think with the timing issue, I'm happy to discuss this with any of you offline. I'm going to be here today and tomorrow, but perhaps we should move on.
Yeah.
Okay.